Well, I think we're ready to go ahead and get started. Thank you for coming tonight. My name is Vivian Ho. I'm a health economist, and I direct the Baker Institute Health Policy Forum, which organized this event tonight. Thank you for coming out at the start of, I'm sure, what is a very busy holiday evening meeting season. So we're delighted to have you here, and I think you're going to be rewarded by a very interesting and informative speaker. We're fortunate to have Bill Sage joining us tonight. He is a distinguished law professor at University of Texas Law School. But the thing about Bill is he really has an extensive background, which I think you'll see from tonight. So Bill, trained and received both a JD and an MD from Stanford. And so he's done all the physician training, but then he went on and practiced corporate law. And then after that has been a professor for several years in the law school at Columbia, but then also took a stint working for the Clinton administration doing health policy in DC. And then beyond that, in addition to being a law professor, he has served for several years as the vice provost for health affairs at University of Texas, and I believe you played a large role in terms of that system, getting ready for new medical schools in both Austin and out in South Texas. So here you have a man who has done corporate law, academic law, public policy, and also university administration. So you can't get any broader than that. And so I'm expecting really great things from this talk. And with that, I'm going to, and you can read the official biography in the program too. With that, I'm going to hand it over to Bill.
Thank you, Vivian. Hi, everybody. I'm happy to be here. Having two microphones is a little daunting. I feel like I'm giving a press conference or something to the White House press corps. Very grateful to the Baker Institute for inviting me and to Vivian for arranging it all and hosting it. The introduction, which is unlike some of the ones I've had, forces me to tell an old story that I seldom tell anymore. So my formative experience in health policy was basically walking into the Clinton White House in early 1993 as a young, newly minted MD JD, and that was the at the time infamous Hillary Clinton task force, since faded from memory largely. One of the things that happened in that process, we had very few opportunities to actually meet as sort of policy folks with the political leadership, but there were a small number of meetings arranged with President Clinton and some occasionally cabinet member or the vice president or the first lady, and I got to go to one of these. It was in the Roosevelt room of the White House. It was all, with Teddy Roosevelt's Peace Prize sitting there. It was all very impressive. And there were several of us there. And at the beginning of the meeting, the person who was in charge kind of introduced each of us very, very briefly. And when he got to me, he told President Clinton and everyone else that I had been trained in anesthesia and in securities law. At which point, Clinton turns around, looks at me, and says in a very loud voice, "That's just great. You put them to sleep and take their money." And since we're so near the Texas Medical Center, and my old friend Tom Feely's back in the audience back there, I'll tell the sequel. About a week after that happened, I was at a meeting involving what was then called the Washington Business Group on Health, and it was kind of an executive committee, sort of healthcare purchasers for very large corporations. And I told the story. It had just happened, and I sort of told the punchline, put them to sleep and take their money, and everyone laughs, and then a voice in the back says, "Yes, and that's just the anesthesia part." At any rate. This talk is called Rethinking the Product, a Path to More Effective Competition in Healthcare. And this is a perspective that I have come to mainly from having to work in two related but not always connected areas of health policy. One is kind of the overall accomplishments or lack of accomplishments of the healthcare delivery system. How well does it do? What outcomes does it generate? How much does it cost, et cetera? And the other is the specific vehicle of U.S. antitrust law, the legal regime that governs competition in the United States. And having in my own work to put these two together leads me to the presentation that you're about to hear. So I thought I'd kind of summarize for you where I'm heading with this. So you may be familiar. In the general political debate, it's usually people who believe in competition versus people who believe in a single payer system. And you generally kind of hear, oh, I think things should be competitive. No, I think things should be single payer. That's not the debate that I'm engaged in. I actually will state something I believe, both as a normative matter and just empirically what's factually likely in this country, which is that, as the bullet says, competition and innovation are more likely to improve healthcare in the U.S. Than a centralized administration that blunts the profit motive. So I am in kind of the unusual position of being a liberal Democrat, incredibly pro-ACA, but also a big fan of private markets. And that's where I start. And then I'd sort of observe that when we talk about competition, whether as economists or real people, we expect competition along a bunch of dimensions: price, quality, choice, and over time, innovation. And if you are a naive adherent to traditional macroeconomic theory, you think that markets will actually not only evolve the optimum in each of these dimensions, but the optimum mix among the different dimensions themselves. I won't say anything about that, but we expect that competition is going to be along a lot of dimensions. I've asked myself, well, if we have this private competitive healthcare system, how come it doesn't really seem to do very well? How come it costs so much in the U.S., which costs a lot, and how come it doesn't really seem to produce outcomes that are better than places that spend a whole lot less? And that's a real puzzle. And the question I ask to deal with that puzzle is, well, don't these dimensions of competition, price and quality and choice of innovation, all assume that we know what we're buying and selling, and that we're buying and selling the things that we really want? And so I would posit in this talk that these dimensions of competition, even if competition seems pretty vigorous, don't really mean much if we're buying and selling the wrong things. And that's why this is a talk about getting the product right. In fact, very little effort by economists, lawyers, policymakers, or others has been devoted to understanding the products, using the term kind of in quotes, and I mean, the stuff, the services, as well as the goods that the healthcare system buys and sells, even though the healthcare system spends about $3 trillion annually in this country. And so my conclusion, and sort of the last point on the précis of the argument, is that if we want more effective competition in healthcare in the United States, we need a strategic focus on the product. And that needs to include both the regulators of the healthcare system and the government authorities that oversee competition through antitrust enforcement. And if those parties are aligned, then the people who are actually buying and selling and making healthcare are likely to end up on the same page as well. And so I am sort of stepping back from whether the competition we have is good competition or bad competition, and saying if it doesn't really work out that well, and I don't think it does, maybe it's because we don't have the product right. And so that's the argument in brief. Now let's sort of unpack that a bit. And a good way to unpack it is look from the lens of antitrust enforcement. Unexpectedly, now that we are post-ACA and the competitive landscape of healthcare appears to be changing, there's a lot of market consolidation out there. Hospitals are merging, hospitals are acquiring physician groups. There's a lot of stuff going on, a lot of transactions, and the economy is generally conducive to those transactions right now. We've seen this before. We've seen this in the 1980s. We've seen this in the 1990s. Transaction volume waxes and wanes. transactions, but we're back in a period of pretty high transaction volume. And as this sort of consolidation and sort of repartnering in the healthcare system proceeds, various people have said, well, wait a minute, we're really nervous about market power. We're really nervous that, these parties are going to get too big, that the wrong people are going to be merging, the wrong people are going to be acquiring, et cetera. And therefore, what we really need to make sure that things work out well is heightened antitrust enforcement. There's a plausibility to this, but I want to challenge some of the details. The same way, a generation ago when I was working in the Clinton White House, there was a broad consensus, even a bipartisan consensus, that if we could just get rid of waste, fraud, and abuse in the healthcare system, everything would be fine. Well, yeah, there's a plausibility to that, but you have to know what you mean by waste, fraud, and abuse, and you have to be on the same page about how you get rid of it, or at least diminish it. And that's what I'm seeking in terms of a policy response to market consolidation in healthcare. So if you look at what the antitrust enforcement agencies, the federal agencies, are doing these days, you get a number of categories. And I think some of these categories are more constructive than others. And so you have the Federal Trade Commission and the U.S. Department of Justice that share antitrust authority at the federal level, and then various states can get involved both under federal antitrust law and state antitrust law. And just to be complete, yes, private parties can sue, and we'll see an example of that. So I have 4 categories up here that I think are interesting in terms of healthcare antitrust enforcement these days. The first category is this basic response to consolidation. If there's mergers and acquisitions, what do you do? And we've seen transactions involving hospitals merging, some of which get challenged by the antitrust authorities, and we've also seen transactions where hospitals acquire physician groups, and occasionally those get challenged as well. This is a category that I think is under-theorized, and there are some times when enforcement is a good idea, and sometimes when enforcement is largely a distraction. A theory that 4 is fewer than 5 or 2 is fewer than 3, to me, is not a sophisticated theory of healthcare competition. There's another category of cases that I think is actually much more constructive these days, and these are what you could call contractual foreclosure cases. These cases basically say, look, in the existing healthcare system, we've got some large insurance companies and we've got some large healthcare providers, and overall, they've got a pretty good thing going. And various things that they could do perpetuate the good thing they have going. And one of the things that has happened is that often in their contractual agreements between insurers and providers, they actually make reference to potential competitors and agree on things that would disadvantage those competitors. So in Michigan, for example, some very interesting cases brought by the Department of Justice because the Blue Cross plan up there put in a series of most favored customer clauses in all of its contracts with hospitals that sort of let the hospitals continue to earn high rates and actually kept other insurers from coming in. Case up in Wichita Falls involving a dominant hospital up there, United Regional, that it built into its agreements with payers a requirement that the payer deal only with United Regional and not with other hospitals. And you realize this is sort of interesting because if you were afraid of a hospital becoming dominant, the fact that it's called United Regional is a clue. And yet nobody pays any attention. I mean, there was obviously a point at which that hospital was other hospitals and became United Regional, and now we don't like the fact that it's consolidated. But that type of contracting practice, I think, is problematic. And when we look forward to the ubiquitous accountable care organization, kind of the latest in-fashion trend in healthcare delivery, accountable care organizations, through their contracting practices, may be able to entrench themselves and disadvantage potential competitors. And I think that's actually an important area for antitrust enforcement. There, I make passing reference to the fact that after the Supreme Court's Actavis decision, there are now cases out there challenging so-called reverse payment settlements between pharmaceutical companies who make patented substances and generic challengers. Why is it a reverse payment settlement? Because typically, if someone who doesn't own a patent starts producing something that's patented, the patent holder sues the new maker for patent infringement, and if there's a settlement of that lawsuit, the ostensible infringer pays the patent owner to not pursue the litigation. These are reverse settlements because the same thing happens, but in the settlement, it's actually the patent holder who pays the supposed infringer rather than backwards, and that can have an anti-competitive effect, and there's been some interesting antitrust litigation around that. And then I think the most interesting recent health antitrust case involves the North Carolina Dental Board. And actually, let me talk about that one first, and then I'll come back to the others. So I thought I'd give you just a little flavor for what's happening in competition policy in healthcare with a couple of examples. And, because our time is relatively short, I won't go into great detail. North Carolina State Board of Dental Examiners case was heard by the United States Supreme Court. Oral arguments were heard in October. This is actually a case that challenges 100 years of professional dominance over health services in the United States. I mean, medicine, dentistry, and 1,000 other things are largely governed at the state level by professional licensing boards that are composed pretty much of the regulated professions. And this self-regulatory model is what a lot of our healthcare system is based on, and it usually goes unchallenged. As a legal matter, the antitrust laws are designed to police anti-competitive behavior by private actors, not anti-competitive regulation by the state. If a state wants to enact regulation rather than enjoy competition in a particular area, federal antitrust laws are not designed to impose on that decision, are not designed to criticize or reverse that decision. This is a little different because the question is now squarely presented before the United States Supreme Court whether a state professional licensing board is really a public actor or is instead, think of it as a conspiracy of members of a profession who can make decisions that disadvantage other professions or non-professionals. This is a case about tooth whitening. In North Carolina, as many other places, if you want your teeth whitened, you can go to a dentist and they'll charge you a lot of money and probably do a pretty good job. Or you can go to a shopping mall and they'll charge you much less money and probably do an okay job. Well, in North Carolina, the state dental board, 7 of the 9 members of which are dentists elected by other dentists in the state, didn't like the fact that there were people in shopping malls whitening teeth. And so they got together as the state board and they sent out a bunch of cease and desist letters, not only to all the shopping mall tooth whitening businesses, but to the mall owners who leased them space, and said, you're all practicing dentistry without a license and you're all liable for criminal prosecution. The Federal Trade Commission, which is constantly trying to advise states on the anti-competitive things that they do in their regulatory agendas, said this one went beyond advising states and actually brought a suit against the North Carolina Board of Dental Examiners, said you guys are actually violating the federal antitrust laws. The FTC won in the Fourth Circuit Court of Appeals, and the Supreme Court took the case and just heard oral arguments. And the interesting thing about the oral arguments is that it really seemed from the oral arguments that the Supreme Court is not sympathetic to the dentists on the state dental board. And they're not sympathetic on federalism grounds. It's not, oh, there's the big bad federal government again telling states what to do. And they're not sympathetic on sort of, well, these are, ethical professionals who serve voluntarily on these boards and we wouldn't do anything to disrupt that process. No, they're actually quite skeptical about the competitive impact that these professional licensing boards have on the availability of cheaper but still very good services that consumers desire. So this, a case you probably have never heard about, will be decided sometime probably in the next 4 to 5 months. I would expect, February, March, or April for this one, not June. And this is really a major case about the way in which professionals self-regulate medicine and other health services in this country. Most interesting merger and acquisition case up in Idaho. And this is a case that is on appeal now, as I understand it. I don't know where it stands in that appeal process, but here you have a situation where for the very first time, a successful antitrust challenge was brought to an acquisition by a hospital, not of another hospital, but of a physician practice. And here you have a hospital chain, pretty large hospital system that has a large facility in Boise, has a smaller facility about 10 miles outside of Boise, and then 20 miles outside of Boise doesn't have a facility, but there's a 41-doctor medical group called the Salzer Medical Group, and as part of the post-ACA project of having integrated care with demonstrable outcomes, presumably to be paid for on a different basis, they acquire this physician practice. A competitor hospital in the same community, Nampa, as the medical group, sues them saying, you've now cut off our supply of referrals because you now control all the doctors. And at the same time, the government sues them, both the federal government and the state of Idaho, and say, well, now you're going to have too much power negotiating with health insurers for primary care physician services. Oh, and by the way, now that all these medical practices are owned by hospitals, they'll be able to charge the higher inpatient rates for ancillary services and not the lower rates that Salzer previously got by kind of going out into the community to standalone facilities. And what's really interesting about this case is that the judge deciding it in the first instance is very explicitly conflicted between the old healthcare system and some new and improved healthcare system, more competitive healthcare system that might be coming. And so the judge says, you know, this I really have to commend the defendants here, because they're really looking ahead and saying, well, what would be the best way to integrate hospital and physician services in the future and to compete in a post-ACA world, and has this quote that says, you know, if this world were not governed by the federal antitrust laws, you know, I'd approve this acquisition and we'll see what happens, because I think it's a good acquisition. But then he decides that, quote, the Clayton Act does not give this court discretion to conduct a healthcare experiment and forces the hospital to divest the physician practice. This is a really interesting case, because here you have both sort of a general fear of consolidation, employment of physicians by hospitals, and the factual matter of who gets to do what in the current system coming up starkly against the recognition that the future system really needs to be different if the competitive outcomes are to be better. So I thought I would, you know, give you at least that much of a lens on current antitrust enforcement before I now turn to my theory of the case, to, you know, what do I think really has been systematically wrong. So I'm not criticizing what the DOJ and the FTC are doing. I'm with them 85% of the time. But 15% of the time, I think they're not quite understanding that many of the transactions they're most concerned about stopping are only trying to change things that really need to be changed. So here's the broader view. The broader view is we waste $1 trillion every year in this country because the healthcare system isn't efficient. And what does that mean? It means we don't spend our money on the healthcare that people value most, and we don't produce the healthcare that we produce at the lowest possible cost. Standard microeconomic concepts. $1 trillion a year is a lot of money. And we understand that the payoff from the reconfiguration of the healthcare system might be improved in efficiency. We worry, especially in an antitrust framework, that the downside is that someone can, you know, acquire and exercise market power to the detriment of consumers. What I try to point out is, look, antitrust enforcement is only a very partial solution here, because antitrust enforcement doesn't really take account of the deep history of regulation and subsidy that pervades our healthcare system and distorts the competition that it creates. It distorts, among other things, the products that the healthcare system buys and sells. Antitrust enforcement just assumes that, you know, whatever's there right now got there for competitive reasons. And if, you know, providers are multiple and fragmented, that was there for competitive reasons. And also assumes that if prices were going to go up or down, the prices have some intrinsic meaning, that the prices are rational prices. To the contrary, if we know anything about our healthcare system, it's that the current market conditions we have are simply the current market conditions we have and are seldom competitive in a real sense. We know that the fragmentation we have in the healthcare system is something we've come to over decades, if not centuries, and doesn't necessarily do us any good. And we know that there really is not an economically meaningful price in our entire system. And I can say that full stop, and the people who live and work in this system know that fundamentally it's the case. Don't want to be blamed for it, but they know that fundamentally it's the case. It's not that we waste $1 trillion because we want to waste $1 trillion. It's not that we don't like efficiency in the healthcare system. It's that public regulation determines the competition we have, and the competition we have is distorted and unproductive. And the sources of the regulatory distortions are legion. They come from the history of physician self-regulation through state licensing boards and elsewhere. They come from the American or North American curiosity of having hospitals and physicians partitioned, but having open medical staff so that even specialist physicians can have private offices in the community and then come into the hospital to treat their patients at no cost to themselves. Here, you want an example of when I make very few friends in Texas? I can go into audiences of very conservative physicians and I can explain to them why they are America's greatest socialists. So the TMA is an incredibly socialist organization. Why is that the case? Because we have trillions of dollars of hospital assets that physicians use at absolutely no cost to them in order to pursue their objectives, both clinical and economic. Physicians do not contribute monetarily. Physicians simply free ride on what we have collectively created in the hospital sector. That's an overstatement, but only a little one. This is the regulatory world, and whether you go through kind of professional self-regulation, hospital-physician relationships, the nature of hospitals themselves, and the way we've created health insurance, you have a world in which a lot of very well-intentioned regulation has systematically distorted the ability of our healthcare system to compete. And this is not sort of, and this is, I think, an important political commentary. This isn't government them, that government did this. This is government us. This is all stuff that over the course of decades or centuries we asked for. And we often had good reasons for asking, and our government systems responded by giving it to us. So yes, we have government to blame, but it's really government us and not government, some remote government that is doing what we don't want government to do. And although this is perhaps an unduly rosy view of the Affordable Care Act, the notion of the Affordable Care Act is not just near universal or universal coverage. It is more efficient healthcare delivery and better underlying population health. It is in many ways an aspiration to pursue the triple aim that's articulated by Don Berwick and the Institute for Healthcare Improvement, which is that simultaneously patients can have a better experience of care, populations can be healthier, and costs can decrease. And that triple aim is both, I think, normatively desirable, but it's realistic given the history of the healthcare system, which has not pursued that aim with any success. So the story about why we waste $1 trillion and have bad competition isn't that we're not smart enough or that we're too lazy to care. It's that the accretion of regulation has left us in this circumstance. So what are the products that our healthcare system transacts in? And I'll give you two basic categories. We have professionally defined products, and then we have insurance-related products. And I would argue that neither category are the products that we would actually want to buy and sell if we thought about it carefully. If we just thought about it in the way that we think about goods and services in other industries, we would never choose to spend $3 trillion, $2 trillion, or maybe even $1 trillion a year on these particular products. Most healthcare products are defined by doctors. I mean, doctors' fees are only 10 to 15% of healthcare spending, but doctors' ordering decisions, for hospitalization, for prescription drugs, for diagnostics, et cetera, that's about 2/3 of the overall healthcare bill, and that's why, in a lot of talks you can take out something like this, an ordinary ballpoint pen, and say that this is the most expensive medical technology in the world. Which in fact it is, and this is not original to me, but hundreds of thousands of pens like this in the hands of hundreds of thousands of American physicians every year are responsible for the discretionary expenditure of about $2 trillion of our money, and that's significant. Doctors define the products. The professional tradition equates a product with an input and a workflow. In many ways, our entire healthcare system is metaphorically simply the contents of a very, very large black bag carried by a physician. Things that he or she can do themselves, things that other people need to do, but when an input is required, when a process step needs to be conducted, take it out of the bag, use it, do it, et cetera. And of course, with fee-for-service payment, once the professions have defined and devised a process step, not a bad process step, but it's still a process step, then they get a billing code. And once they have a process step and they have a billing code, they have a product in the system that we have. So once the physicians have the billing code, then the suppliers create a billing code for offering what they do. And at the end of the day, you have disaggregated products, which consist of process steps and inputs. And there's almost no incentive for productive efficiency because you almost never assemble these inputs and process steps into anything that is intuitively cohesive, the way we would expect it to be in other industries. There's a great YouTube video and essay on if air travel were like healthcare, where every aspect of the travel experience needs to be separately arranged, negotiated, and purchased. We don't do that. We want to get on a plane and go where we're going with our baggage with us and with the pilot being part of the airplane. Also, if you understand the professional determination of process, and so how products get determined by professionals as process steps, you realize why our healthcare system is so concerned with reimbursement. That term reimbursement is, in a sense, the repayment for having engaged in a particular process. And if you talk to most healthcare providers, they're very, very aware of their reimbursement. They're not very aware of their costs of production because they're not actually producing so much as sort of adding a process step, using an input, and then being paid back for that one thing that they've done or employed. And this is a serious problem for health information because if you look generally at the existing compendium, wrong word, look at the data, the healthcare data that exists in the world today. For the most part, that data reflects payment, not care. Because all of the incentives when products are defined professionally are you collect the information that you need to collect in order to get paid. Health IT can do much more than that and is doing much more than that. But that is, I think, a fairly accurate statement of the starting point of the history. Our system has collected the information it needed to collect in order to get paid. And that's because so many of our products are professionally defined. When they're not professionally defined, we define our healthcare products according to insurance. And most of these are not cohesive in themselves. They are, again, loose assemblages of covered benefits, each one of which consists of a category of professionally defined processes or inputs: hospital care, physician care, prescription drugs, et cetera. Now, this isn't universal. There are a few insurance organizations, think prepaid group practices, closed panel HMOs like Kaiser, for which coverage, that premium payment, actually means comprehensive care for all medical needs that a beneficiary needs in a current year. And that is a budgeted system, but it's certainly a system where productive efficiency matters. But that's the exception rather than the rule in American health insurance. Most American health insurance is an aggregation of these process steps and these inputs. And in the post-managed care backlash world that prevailed from the late 90s through the enactment of the ACA, the tradition became, the practice became for insurers to sign contracts very broadly, not narrow networks, not even tiering necessarily, but very broad networks that included all or almost all hospitals, all or almost all physicians. And these contracts were really just about setting terms of payment for each of these process steps and input. When you look back on managed care was supposed to do a whole lot more than annual fee negotiations over faux products. Managed care was supposed to integrate services. Managed care was supposed to improve quality, reduce waste, a whole bunch of things that managed care never did. Why didn't managed care do it? Not because managed care necessarily didn't want to do it, but because we made it undesirable and unattractive for managed care to do it. We enacted laws that said you really can't do this. We had a consumer backlash that said we really don't want that. And we, again, ended up with very much what we said we wanted. Which was a stylized set of contracting practices that set prices and fees for products that are not real products. So what's an alternative? Alternative is kind of a simple notion of the assembled product. What is an assembled product? An assembled product is a saleable unit that a consumer understands for two reasons. What they're getting is intuitive, and whether they've gotten it is measurable. Very few people want a CT scan. Very few people want a day in the hospital. Very few people even want a particular prescription drug. There may be times when people want an expert conversation. That's possible. But many of the things, most of the things that we transact in are not things that are intuitively beneficial to people, and not things that after you receive them, you can actually measure what benefit you've gotten from having them. I can't measure the benefit of a CT scan. I can measure the benefit of a diagnosis. I can't measure the benefit of a hospitalization day. I can measure the benefit of a recovery from an illness, an injury, or an operation. If products are assembled, you can calculate the cost of producing them, and you can price them in a way that's meaningful. If products are assembled, you can place a warranty of some sort on them, a warranty for quality, a warranty for safety. And this is, I think, one of the most practical implications of this approach. We have a way in health policy of jumping from the old form of fee-for-service payment to a new form that we often call something like capitation, risk-bearing. That's a mistake. There are organizations that do very well bearing risk and providing real care, the Kaisers of the world being a good example. But for the most part, it's not that fee-for-service is bad, it's that the services in the fee-for-service are not real products. We can create plenty of fee-based products that actually do intuitive and measurable good. And the other way of saying this that's highlighted in the slide is the warranty risk of what you provide is not the same thing as insurance risk. Lots of manufacturers of lots of stuff provide warranties and often take out commercial insurance to pay kind of stop loss on warranty exposure that might turn out to be more than they can bear efficiently themselves. But when you say, your hip surgery is going to work, or your diagnosis is going to be accurate, that's not the same thing as saying you're never going to get sick again. It's just the warranty risk on what you're purchasing. It's not the insurance risk on how healthy or unhealthy you are for a time period going forward. So that's a really important insight when you start thinking about coherent products, that you can have warranties that address warranty risk without going immediately into a world of prepayment, capitation, and insurance risk bearing. Also, it's really important to understand that there are assembled products that are complicated and assembled products that are simple. There are assembled products we have in the world already, assembled products we're trying to create, and it's not that every assembled product is a big assembled product. Some are little, but as long as they do intuitive and measurable benefit, as long as they can be warranted, as long as you can calculate their costs and apply a meaningful price, I think you've made an improvement in the world that we currently have. So you can have a package diagnostic workup for a set of symptoms. Maybe you have two different products. Maybe the first is, okay, I don't think this is really serious, tell me what it is. The other is, well, this is really, I think, serious, or I've had it for a while, or it seems like the first pass didn't work, do something fancier and definitely tell me what it is. Each of those perfectly plausible product. You can have all-in-one treatment for an acute condition. You can have periodic maintenance care for a chronic condition. Again, the basic point is, if you start thinking in terms of assembled products, there's lots of assembled products out there. We have some of them, we don't have many of them, and we spend most of our money on unassembled products. If you look at the world that's out there, you'll see that we're actually engaged in trying to improve the product in a few ways. So we've had a number of pilot projects, demonstrations, and even ongoing business practices trying to bundle process steps and inputs into case rates or episodic payment programs where you need cardiac care, you need a hip replacement, you need some other joint replacement, et cetera, et cetera. You get a single price quote, and that's the all-in treatment. That's the facility fee, that's the professional fee, and maybe that covers some aftercare pledge that is similar to a warranty, 90 days at Geisinger or whatever it might be. And some of these programs are very regulated and governmentally sponsored. Some of these are, a bunch of cowboy conservative surgeons just doing what they think is right. If you've never gone to the website for the Surgery Center of Oklahoma outside Oklahoma City, go to their website and you will see a nice little drop-down menu that basically says, we don't believe in the ACA, we don't believe in a whole lot of government intervention. Guess what? We believe in good care at a fair price. Tell us what your condition is, click on the drop-down menu, and we'll give you a price quote for what we would provide you. And you want your joint replaced, you want a few other types of surgery, and you can get a fixed price quote from their drop-down menu. They have a nice little disclaimer, says there are times that the care is more complicated than that, but they stand by their prices, and by the way, their prices are considerably lower than the same procedures would cost at the nonprofit community hospital in Oklahoma City that is often their major competitor. There's some other kind of wonky health policy projects ongoing about value-based insurance design. There's a whole bunch of things involving accountable care organizations. And then there's, I think, a very strong movement towards more transparency, information disclosure about quality, information disclosure about price. Not all of these are associated with an idea of assembled products. Many of these are associated with the process steps and inputs that we currently transact in, but some of them are associated with assembled products, and I think those are good. So far, the bundling programs that we've engaged in, particularly this one that's referred to as the ARC-RAND Integrated Healthcare Association experiment that just concluded last year, have not been terribly successful. But I think those of us who follow this area don't feel that the problem is that bundling is a bad strategy. It's that we've often been doing it in very mixed message environments where we really haven't given it the time that it will take and the attention that it will take to dislodge the current system practices in favor of a newer approach. If you want to read more about this, the reference to a Health Affairs article from last spring is included for you. Here's what assembled products aren't. And by putting this list up, I'm trying to emphasize that This isn't a market replacement project I'm engaged in. It's a market facilitation project. That I really care about what markets think products are, not about what I think markets should think products are. So we're never going to get to real products by taking the lists of things that government pays for today, like Medicare DRGs or CPT codes, and creating a new master list. That's not the idea. Now, we want things to come off the list and better things to go on, but it's not just, oh, let's sit down for a year and reinvent a new master list and apply that, and that'll work. I don't think that'll work. Assembled products isn't cookbook medicine. Doesn't mean that every single person gets the same treatment. It's that people get treatment that they know they want and that you can tell if it worked after they've received it. Assembled products doesn't mean that we no longer care about patients over time and about building therapeutic relationships with patients, and all we care about are discrete transactions. I would argue that's the problem with the current system. The current system's all about discrete transactions. It's about process steps and billing codes. Can't get more transaction-oriented than that. At least if you have an assembled product, we have to care about the patient until the patient receives the benefit the patient says he or she wants. Assembled products don't require everyone to immediately be a Kaiser. In fact, if everyone were a Kaiser, probably wouldn't need a concept of assembled products. I think we need a concept of assembled products because what we have to do is take our very fragmented fee-for-service based system and over a rather short period of time, say 5 to 10 years, make it perform better, rather than think that we can replace it with fully integrated organizations. Neither does this hypothesis or approach reject the prepaid HMO model. No, the prepaid HMO model is terrific in the places where it is traditional, successful, and people, sort of the capital investments and the cultural expectations work. But in most places, the prepaid HMO model doesn't seem to work. I don't think we're going to make an instant transition to assembled products or a universal transition to assembled products, but we have to start thinking in these terms if we're going to make progress. And I'm really trying to convey this not as an accusation that the existing healthcare system is morally wrong, but just we have to acknowledge the reality that we've created over a century if we're going to actually have competition that works. Now, I want to leave plenty of time for questions and discussion. I'm not going to give you these details, but I'll provide the slide for you. I think you have a copy or can email you a copy. There are many ways in which antitrust analysis needs to change to take account of the desirability of assembled products. And this goes from how you define the market for the product to what you describe as a buyer or a seller in a particular market, or what you consider a vertical or horizontal transaction, and how you approach everything from sort of joint production and pricing cases to exclusionary conduct cases to the sort of mergers and acquisitions. But this is more sort of an antitrust law lecture than a policy lecture, so we'll skip that. And then sort of as a final slide, sort of what are the next steps? I mean, what are the sort of core insights to move over a reasonable period of time from the faux products we have to the assembled products that we know we need if competition is to be more effective? And so top of the list, not surprisingly, is competition enforcement and regulatory policy have to be talking to each other. If we have such poor competition because of all the regulations that we've created over decades, we have to be able to evaluate and unwind and modify some of those in order to have better competition. We are engaged in two consensus areas of healthcare delivery reform right now. One is payment reform, and the other is information disclosure, which we like to call transparency these days. I would argue that we need to take both the payment reforms and the information disclosure initiatives and orient them where we can explicitly to assembled products. Of the things that is both the regulatory matter and an antitrust enforcement matter that we could do, I think the most important thing is to get new competitors into the mix. The people who are currently competing are so used to competing over artificial products that it's going to be very hard for them to compete over real products unless we allow other people in to compete against them. So removing all the regulatory barriers to entry, scrutinizing the agreements among the existing market participants that perpetuate these products and deter entry by others, all of that I think is an important next step. When we do come up with a kind of new idea in healthcare delivery, like clinical integration, non-financial integration among healthcare providers, or when we talk about accountable care organizations, we shouldn't just turn them into insurance risk-bearing organizations. If anyone here is involved in or operates an ACO, particularly a Medicare ACO, you will have already realized that only a hair's breadth separates a well-designed ACO from a Medicare Advantage plan, from a Medicare HMO. Medicare HMOs are great, but that's a risk-bearing organization. We can do a whole lot with the ACO construct that's built around assembled products and not only about risk-bearing. And then I would draw significant attention to the bottom point. If you're trying to look for, what's the miracle technology that's going to fix healthcare, this is a really bad example of it because it's an iPhone 4, it doesn't even have Siri. But if you're going to find anyone, a smartphone's the closest you're going to get. And as you probably all know, there is finally a lot of entrepreneurial investment in mobile health and in things that I would describe as upstream health and medical technologies. And this upstream competitive space has never been a profitable one, mainly because we have just poured limitless money into the downstream, into the doctors, into the hospitals, into the things that are, really systematically last-ditch investments. Now that money is pouring into the upstream, I think it's really important that competition be allowed to thrive in the upstream. And the dividing point between upstream and downstream health is actually very easy to articulate. Downstream, there are patients. Patient is someone who is living his or her life, suffers a health-related setback, is removed from his or her life in order to address that problem and then hopefully restored to his or her life. That's the downstream, and that's our system as we have designed it and as we invest in it. In the upstream, there are no patients, there are just people. There are people who live their lives, and in the course of their lives, various things happen that involve their health. Either their health could be maintained or improved or a minor problem addressed, and this can all happen without taking you out of your life. And that upstream space where people are people and not patients is a really important competitive space, in my opinion. And as important as it will be to reconfigure, to the extent we can, the products in the downstream space to be assembled, it's really important to let new competitors enter the upstream, let competition thrive, and evolve things that we can't even imagine exist today, but may do us a lot of good for a lot less money in the future. And since it's always nice to end with a cartoon, well, I'm afraid you've had a paradigm shift. So thank you very much, and I look forward to your questions. Yes?
That the consumer, the patient, doesn't have ownership of their own information. Okay, so it's a system where I want information about my blood, I have to go to a doctor, sign for lab tests, labs go to them first, and then to me, or I have to pay for that, but it's really my information. So assuming that that's correct, do you think that if consumers or patients had control over their own information, that would have an impact on what you're trying to do?
So the question's about control over health-related information and the suggestions made that today the information that exists is in the possession of, even if it's electronic, it's accessible mainly to the healthcare providers and insurers and not so much to the patients. And would patient control over information help? Well, I think people controlling their own health information would help a lot. And you're absolutely right. We have transitioned from a model of physical custody of a medical record in a healthcare facility to a model of electronic transmission, but we really haven't rethought either what that information consists of. In other words, things that are not just either the historical, traditional training of what you're supposed to gather as a medical or health professional, or the things that the healthcare system needed to gather in order to get paid, to having actually an information base that is routinely useful and continually updated and relevant to people's experience. Yeah, absolutely. I think that if you conceive of health information as being in the possession of the consumer and the control of the consumer, you will quickly find ways to make that information have more utility, and hopefully that utility would mirror the notion of, you know, the service you're getting being actually a service that will do you some good.
I think I really got what you said, what your approach is. Are there other approaches like your approach in terms of time-space continuum and that kind of thing that are different? Can you tell us about what other people who think about this like you have done, what some of their approaches are?
Yeah. So what are the other approaches? So there are approaches that say our system should be a general social resource funded by tax dollars and not financed through individual consumerism, even subsidized individual consumerism. And so if you look to kind of Western Europe and those social democracies as the paradigm case for that, you'll, I think, find a couple of things that bear on this analysis. One is that, yes, to the extent you budget an organization, you don't really need to have a notion of assembled products that's as strong, because the budgeted organization has to serve all the people who are assigned to it, or all who are expected to access it acceptably for the overall budgeted amount. They're going to have to come up with their own ways of allocating the budget and making services available, but they don't necessarily need to have a transactable product each time. So if you adhere to that version, you don't necessarily need an assembled product. The reason I think even those systems need to take account of this type of an approach is that all of Western Europe is now spending more on healthcare than they think they can afford. You know, we passed that point a while back. Even Western Europe now is at that point, and so they're looking to ways to use competitive mechanisms. And I think if they're going to use competitive mechanisms, they better use competitive mechanisms around real products and not competitive mechanisms around faux products. And then there are people here who love the insurance framework. They love the prepaid version. You know, so everybody should be in a Kaiser-style organization, and whether that's done in one set of facilities or it's done by contracts with a bunch of doctors in offices who get risk-bearing payments, that's their desired approach. And they care less about the assembled product, meaning sort of here's your hip replacement, more about the population health management of the assigned population. And I think that's an important alternative, particularly if you could create systems like that went deeply into community health and population health, but I've yet to see one that does. So I'd say both the kind of social democracy approaches and the prepaid system approaches are alternatives to this.
Could you comment on how the assembled product setup would affect essentially liability and malpractice issues?
So I'm an MD-JD, so I'm typecast to work on medical malpractice issues. And indeed, I've spent a lot of my career on medical malpractice issues. So if I get to do one little bully pulpit thing, medical malpractice is a minor influence on health system performance in this country, not a major one. And Texas post-tort reform, it's an incredibly minor one, even though it's taken physicians particularly a long time, almost a generational washout, to appreciate that fact. That said, actually, I think assembled products make liability concerns much easier to deal with, because when you are designing an assembled product to perform to a certain standard with a basic warranty for safety as well, you kind of are all on the same page when you plan the services, the steps that will execute that product. So when you're informing a patient in advance of what the risks are associated with their care. It's not the risks of each process step, it's the overall risks that what you provide won't perform as expected or will subject them to some serious outcome that wasn't anticipated. I think once you have that conversation, you on the provider side are much better equipped to minimize the risks. So I actually think the assembled product approach does better from a liability perspective.
Let me kind of shift to a kind of different kind of setting. I'm a family physician that works within the county hospital system here, and so we have no competition. Nobody really wants our patients. Yet, you know, when Harris Health rebranded, they really wanted to kind of be attractive to the, you know, the exchange plan kind of patient or even private payer. And yet, as I see it, from my perspective, down in Sharpstown, is that we have patients that are leaving our system who have been there for years, and you know, the nature of the business here is that we have a lot of competitors, and they will want to leave. And my fear is that we will no longer be relevant, that we will be basically saddled with the pretty much done document, and without comprehensive immigration reform or some sort of expansion, however, you know, the state decides to do it, you know, we won't be relevant, and the competition piece, you know, we will get competed out. I don't know what you have to say about the nature of safety net hospitals.
So yeah, so the questions on safety net providers and, you know, this incomplete voucher that's now being given to the exchanges to allow people who were previously dependent on safety net hospitals to access the more general health system, while there's still a lot of need, particularly among the undocumented, for safety net facilities. So yeah, I mean, this is a much broader policy question than kind of a, you know, the notion of the product that you're offering. One thing you know, is that the mainstreaming of patients never works quite as well as we would hope, in part because they are now mainstreamed into a system that does not necessarily meet their needs. And, you know, I think that's the reality of it, is that the perception is that the safety net provider is worse quality because all the people who have money go elsewhere. The reality is that all the people with money who go elsewhere still often do not get the care they deserve at a price that's affordable. And it helps that I have the medical degree, and I have a Texas medical license, though I don't practice. I'm not trying to pick on doctors or pick on hospitals. I'm just kind of stating very bluntly something that is, general knowledge, is our overall system really doesn't perform that well.
I was wondering, for the assembled product, how do we go beyond process mapping? There's also duplication of the process mapping process. I guess going beyond that, and how do we actually get a bundled or an assembled product?
So process mapping, I don't consider myself an expert on the types of process mapping that's now done. A lot of the process mapping that I've seen done in hospitals these days is, I think it's a very useful exercise because it's some attempt to understand internal costs. We really, because we've oriented our information so much to billable codes and reimbursement, we often have ignored just how people and hard assets are deployed in the day-to-day care of a patient. So I think process maps are great for beginning to develop that. I think that if we moved more of the market to assembled products, the process maps would turn out to be even more useful, because you'd start to see a direct equivalence between the processes that you combine and sequence and an outcome that you're actually being paid for.
I guess a follow-up question.
Sure.
In terms of coordinating the process mapping undertaking of that, like if multiple hospitals are doing it, but then if there are too many and it's just continued fragmentation and duplication of the same processes that are like let's say knee surgery, which has been mapped out, I guess, is being tested out in one hospital and multiple hospitals are doing the same process mapping. Is another form of waste, I guess.
Yeah, I mean, it's interesting. I mean, you know, in every industry, competitors do some things internally and joint venture other things and you know, share public information resources for still other things. I think that's something that competitive processes just work out. I don't mind that. So the duplication that might be inherent in that doesn't offend me in any way, because what I really want to see is more genuine competition. We do struggle with this, of course, because whenever we try to create a standard set of informational utilities, you know, a community health information network, a health information exchange. We have to deal with the fact that certain tend to be larger participants don't really want to share information into that network and would rather do it themselves. And yeah, there are plenty of frictions involved in that aren't necessarily efficient, but I would never support trying to dictate what people can do for their internal information exchange. One in the back, and then I'll come up here. Yeah.
I wonder if you would talk a little bit about the demand side for the assembled products. Is the demand, in your view, going to come first from Medicare or Medicaid insisting on these, or from large employers insisting on it, or the new individual marketplace, which frankly would be my guess, where there's much more of a price sensitivity on the consumer's part? They want to buy the lowest price insurance product out there, which will cause insurers to say, okay, how can I find and deliver this bundle of services for lower?
That's a wonderful question. It's such a good question. I will make it a new slide for the next time I give the talk. So A and C, but not B. So yes, you're absolutely right that the individual exchanges may be a really nice way, opportunity for people who are buying their own coverage to buy coverage that makes sense to them at the price point they end up paying. And I think if the insurance exchanges work well, you will see not only a move towards narrower networks, but a move towards more coherent products. Medicare has to happen. You know, Medicare, though it's an administered pricing system, though it's regulatory, is such a dominant payer for so much of the delivery system that if Medicare has policies that are inconsistent with progress doesn't happen. So I think Medicare absolutely has to be on board with bundled payment experiments, with a bunch of things that would move towards assembled products. I think large employers won't do it. I actually think, and I've been told, that there's no market for this with large employers. That large employers basically just want to know a premium equivalent and don't want anything that is potentially controversial, that because so much of what most large employers want is just to play to the lowest common denominator preferences of their workforces. They don't want to be seen as changing what people get, unless the people themselves ask for it, and the people themselves don't ask. So I don't see, I mean, there may be the occasional, maverick large employer that really wants to innovate in this area, as Alcoa did a generation ago, and perhaps Safeway does today, but, for the most part, I think that on the demand side, this is Medicare and individual purchasing and not large employers. Yes?
Could you discuss the problems of orphan drugs? They cost so much to develop, and then when they are approved by the FDA, the cost to supply them to the patient is hundreds of thousands of dollars. How do you feel the system ought to deal with this problem?
So I recognize the problem. I'm afraid that's neither am I an expert on orphan drugs, nor is it very closely related to kind of the talk on products. Though one thing about drug development that's always so interesting is that you have a pharmaceutical sector that has almost always been quite single-mindedly driven by the profit motive and available market opportunities, embedded in a system that was supposed to be professionally driven, ethically driven, charitably driven through hospitals. And this is not a satisfying answer, and I hate for this to be the last answer because it's probably the weakest I've been able to give. But one would hope that in the course of improving the usual products that the system buys and sells, to some extent, pharmaceutical inputs would be more efficiently incorporated into those products, and where you do find that you're in a situation where there is no economical way to provide an important therapy to a small number of people, that's where, to me, the government does step in and provide the social subsidy. God. One word. Okay.
You made a comment before about large corporations, but in most large corporations, they're actually paying for they're all self-insured. So they have a tremendous incentive to find ways to reduce their costs if they can put the mechanism in place and they work with insurance companies, but the insurance companies just administrate. They end up sending the bills to the companies. The companies have the ability, if they can put the systems together, to find the best cost-effective services for their employees. So there is an opportunity to, I think, do what you want, where if a corporation understands what an employee's need is, perhaps they can go and find the most efficient, cost-effective place to get the outcome that they need.
So thank you, because you've given me an opportunity to end on an even more controversial statement than perhaps I began with. So I completely agree with half of what you said, and I am perplexed at the rest. So what do I agree with? I agree with the statement you made in passing that most health insurers really don't bear insurance risk, and by and large, their incentives are to process claims efficiently given the current system and take some financial reward for doing so rather than change the system. So when I look to the world of private insurers, by and large, I do not see organizations with strong motivations to change from the existing to a better set of products. But then the puzzlement comes around the large employers and the self-insured employers. In theory, you should be right. In practice, I haven't seen it. And part of it is that at the end of the day, this is a component of employee compensation, not a dollar cost to the employer. And part of it is that employers and the bureaucratic, the internal organization of large employers that has grown up around human resources and benefits management is very much a product of the system that we've had over the last 30, 40 years, and I don't think they necessarily see that system as failing to the degree that I do. But I wish I could understand and explain why large employers have not actually performed this role, but I just haven't seen it. Well, thank you all very much.
I've given 6 or 7 talks about the Affordable Care Act around Houston since July, and so it's so nice to not have to be the speaker. But more than that, Bill really illustrates to us that it's not just the Affordable Care Act that matters in terms of getting health care right. We have to think much more basically about the product that we are trading in this market to get everything fixed. So thank you so much for giving a very insightful talk on this topic.